Okay, good evening everybody, and thank you all for coming out this evening. I know it's always hard when you have to leave home to come out to something in the evening time. Hopefully you'll feel that this will have been of some useful information to you. What I'm going to talk about, what I've been asked to talk to you about, is recovery. And trying to think about this in relation to what I was going to say here this evening kind of gave me a number of challenges. I'm used to teaching students, I'm used to teaching people who have no knowledge, who are coming to this as a very new subject. So the way I normally approach it is very much in an informational way, given the evidence base. But today I was trying to take it in a slightly different direction, because I realise we have people here who all have their own experience, all have been on their own journeys, and if they haven't been there themselves personally, they have family members or friends or colleagues who have equally been on a journey of recovery, or maybe not on a journey of recovery. And one of the things I want to do this evening is maybe to challenge our thinking slightly around the whole notion of recovery, and is recovery possible or even desirable for everybody? So there may be some little few controversial points that I introduce. First of all, I wanted to begin by kind of saying that there's been a rapid assimilation of the notion of recovery into the ideas around mental health, mental illness, mental health care and services. And if we really think about it, it's happened really in the past 20 years in this country. And indeed, if we look at the United States, if we look at Canada, Australia, and the Western Europe in particular, recovery has really become a movement very, very rapidly. And that to me signifies that we were ready and ripe for change within mental health and mental health services. So it has been an amazing assimilation. When we think that ideas around mental health and mental illness had been established for about 250 years with asylums and with inpatient services, those kind of historical bits were there for a long, long time. So it's been a massive shift in the past 2 decades. It's become really the kind of the language and the discourse of service users, clients, whatever we want, patients, whatever terms we want to use, of professionals, of service providers, of the community, of the media, of journalists. It's been very readily and very easily taken on board. So it's become the kind of the parlance that we use now on a day-to-day basis. It has also emerged in parallel with the increasing concerns about mental health and mental health care issues in society generally, not just in Ireland, but internationally and globally. We're very much acutely aware that there's an increased recognition that mental health issues are very pervasive. And when I've looked at some of the recent information, they say that there's more people who actually experience mental health problems than don't in the world, if you were to take it over the lifespan of people. So more people need assistance at some point in their life, be it for mental distress, be it for a recognised illness like depression, whatever. But at some point, most of us will all need some intervention to help us cope with the day-to-day realities of our world or what's happened to us. So there's an increasing recognition and increasing burden. And one has to ask, is there some sort of economic factors determining this move towards a recovery movement? And I'll come back to that as we move through. So recovery has been presented as this kind of new idea, new paradigm for mental health, something that's emerged in the past 20 years, and it's a new way forward. It's seen as a system that can alleviate pressure on the health services generally. It's also seen as more client or patient or service user centred, and it's seen as emancipatory. Now, while those things look very good on the surface, it may not be all that it's cracked up to be. I've been working around in mental health since 1978, if you want to do the calculations. It makes me probably a lot older than you might think I am. So I've been around. I would have worked originally in St Brendan's Hospital. I've worked in St John of God's Hospital. I've worked in the UK. I've worked in the US. So I've had an experience of a number of different systems. So I've come to this notion of recovery relatively recently in my career. More than half my career has been over before this kind of stepped up to the mark. Not that I didn't always recognise something was wrong and some things needed to change, but this new movement kind of emerged and became very much the driving force. We tend to think, and this is the definition that most people are kind of aware of, Anthony's definition, around the 90s, 1993, and how we were defining recovery as a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and/or roles, a way of living a satisfying and hopeful life, and of contributing to life even with limitations caused by illness. Includes development of new meaning and purpose in one's life as one grows beyond the catastrophic effect of mental illness. I've always had a bit of a problem with that, because it seems to push all of the kind of the responsibility for recovery onto this individual, onto the one person, that you are the master of your destiny and you can do it all for yourself, which of course we know isn't really true in the real world. We need structures and systems and support to help us recover. We can't do it alone. Nothing in this world can we do on our own. And Anthony's definition, while it's very nice and very aspirational, I think at this stage is probably somewhat redundant, because it puts too much responsibility on an individual who's already struggling to cope with the world in the day-to-day life that they're trying to lead. That's aspirational for any of our lives. And that to me is kind of it's very purposeful, it's lovely, but actually I don't think it bears relationship to the reality. If we look then and think about that, is recovery possible and is it desirable for everybody? Are we now beginning to use recovery in the same way that we use the asylum system and institutions to say you must live up to these expectations, you must become normal? And are we using recovery as a new way to normalise people and to make them kind of fit in to, a certain idea about what being recovered actually means? Because there's a lot of expectation there. Are all personal goals allowed in recovery? If I wanted to take to the bed for a month and ring up UCD and say, well, guys, I have a personal goal. I'd like to stay in bed for the month and just kind of chillax, look at Netflix, read me books, hope somebody will bring me food or just pop out to get food, walk the dogs. I don't think my employers would say that's an acceptable personal goal, because we're paying you a salary and you need to be here. So all personal goals for anybody is not really it's not really permissible. There are rules and regulations in society that we all have to abide by, unfortunately. And the same with people who are in recovery. So this notion that recovery can be whatever somebody wants it to be probably is a little bit misleading. Sounds lovely, sounds great, but might be a little bit misleading. What about the people who don't want to engage with services? What about the people who don't want to take medication? What about the people who don't feel that they have a diagnosis of schizophrenia, or they don't feel the voices in their head are a symptom of an illness? Are they recovered, or are they not adhering to the system? So we have to ask these questions. Tomorrow evening I'll be running a group for people who hear voices in North Inner City Dublin. And a lot of those people don't believe they have a diagnosis of schizophrenia. They don't want to take medication, or they want to reduce their medication. They're still getting up every morning, they're still going to work, they're still doing the ordinary stuff that everybody has to do. The fact they get into the group on a Thursday evening, every Thursday evening, shows how well they're coping. So are they recovered? And by whose definition have they recovered? So we need to question some of the assumptions. That's not to say that recovery notions are bad, because they're not. Certainly a better kind of thing than we had before. But are we abandoning some people if they don't recover? So do you have to recover to be a good service user? So these are some of just the challenges that we start to think about when we really start looking at recovery. And is recovery becoming a substitute for specialist discourse, what we used to talk about, mental illness and all the sorts of language that we used around mental illness that kind of excluded people? Are we now using the recovery discourse as a way of kind of replacing some of that? And does the wholesale acceptance of recovery lack sufficient critical review? So do we need a little bit of dissenters to say, well, hang on a second, have you thought about this? Have you thought about that? Because we know if everybody jumps one way or the other, we can miss things. It's not that we want to, kick it all out or kick it into touch. We want to make sure that it's actually appropriate, and in 30 years' time not be looking back and saying, God, didn't we do a terrible job? Like we're now looking back at things like the asylums and saying, weren't they terrible? When they started off, actually, they were the best option for people. They were taking people out of prisons and jails, but history has a tendency to repeat itself unless we're critical and unless we look at things and question things. So, if we want to look at recovery, as we said, it's been presented as a new kind of paradigm, but actually when we look at the history of recovery, we see that actually it can be traced back to the 1930s. And to this guy called Abraham Lowe, who was the director of the Neuropsychiatric Institute in Illinois. And basically, he set up this group called Recovery, Inc. back in 1937. So recovery isn't a new concept. This notion of recovery has been around for a hell of a long time. Maybe in slightly different guise. The emphasis was really on self-help. And what he was keen to do was he was keen to prevent, kind of relapse of mental illness and to forestall what he called chronicity. So he didn't want people becoming long-term users of services. And it's also interesting that the first 30 founding members of the group were people who'd been discharged from the psychiatric services themselves. So the whole notion of peer mentors and peer group support was already kind of enshrined in those areas at that stage. It also emerged from the international pilot study on schizophrenia. Originally, everybody thought schizophrenia, once you had it, that was it. Your number was up, abandon all hope. But in actual fact, when they studied it over the long term, what they found was actually most people do recover. It might take them a while, but recovery does happen. So this notion that people didn't recover from illnesses like schizophrenia, again, we're beginning to be debunked. And that started a kind of a set of ideas. Now, that was in the 1930s. Look how long it's taken for this notion to move in 2018. So we're talking nearly 100 years that recovery has been on the go, and yet it's only in the past 20 that actually it has got a real kind of surgence. Yet the ideas that came around schizophrenia from Kraepelin and those other people originally in the late 1800s, early 1900s, still prevail. If you look at any medical textbook, the same ideas are there that were there 150 years ago. So you have to question, why has this suddenly become a kind of a new set of ideas? In the Irish context, we've really gotten on board with recovery in the past 15 years. We've started moving our ideas away from custodial, institutionalised, totally medically dominated services to ones that were more facilitating, more empowering and more recovery orientated. And that has been a really good thing. There's been a gradual shift away from the whole notion of chronic mental health problems to things that we talk now, we use language like things that are enduring or persistent. We don't tend to use chronic because chronic kind of has a sense of, well, there's no hope. At least if something is persistent, diabetes can be persistent, it endures. Asthma is persistent, it endures. So there's a notion that somehow there's no difference in having a mental health condition that lasts slightly longer than the average illness, that there's no greater shame associated with that. That's not to say it's the same as diabetes or asthma, because it probably isn't. But this whole notion that we've taken people out of this, and I like Hopper's idea of removing people from the segregated company of like-damaged others. I kind of like that notion because I always say, and I say to the students, would you put everybody who's had a broken leg together and ask them to socialise together? Or everybody who's had a heart attack? Would you say to them, look, you all should socialise and live together, actually, and maybe go out and have a social life together? You have nothing else in common except your heart attack or your broken leg. But because based on that, we think you have a similarity. And when we ask people with mental illness just to socialise with other people with mental illness, we're kind of saying the same thing. You're being defined by your mental illness, not by your personality, your likes, your dislikes, the core bits of who you are. The illness is only one small dimension of it, it's not the totality. And sometimes in mental health services, we fail to recognise all of the other varied, wonderful bits of people that we don't tap into because we spend so much time focusing on the illness. And recovery has given us a way to actually move beyond that kind of notion of and look at people in a more holistic way. It's also a move away from this notion that recovery was somehow happened at a distinct point in time when you were back fully to health. So, when your voices were gone, you were better. When you were no longer feeling depressed, you were better. When you're no longer blind, we can give you a job, or when you're no longer paralyzed. It's the same notion that we have, that somehow you must be free of all these symptoms before you can go back and live your life. And what recovery is saying is actually, no, you can live your life and learn to cope with some of this stuff, because actually this is part of your life and it needs to be recognised not as this additional bit, but as a core piece of you that you need to learn to live with. Like the people I'll talk to tomorrow night who are going to work, despite the fact the voices are driving them around the twist. They'll come in and say, really bad day today, really had an awful time. We'll all sit down and talk about it and whatever. And it gives people sufficient strength to go to next week. So it's about learning to cope and learn to live, even though they still have things going on for themselves. The national policies that are really important here in Ireland are things like the Vision for Recovery, model in Irish mental health care, Vision for Change, the Best Practice Guidance for Mental Health Services, and the National Recovery Framework. The last two are the more recent ones that have just been published within the past kind of couple of months. And what they emphasise really is that the recovery in mental health services emphasises that the expectation of recovery for everybody. And, that's a good place to start, with the presumption that actually everybody can recover. But people will recover in different ways and at different speeds. Promotes the whole notion of self-management. And self-management is great if you have the energy and the capacity to do that. But it's about handing over power to the person. It's about saying, let's look at what you can do and how I can support you to do that, as opposed to saying, there you are now, go off and learn how to take your tablets and do whatever you want to do for yourself, self-manage. Self-management needs to be, a collaborative practice between the professionals and other services and the person. None of us live as an island. Any of us with a health condition need the support of our professional carers. We need backup. We rely on them to actually help us to navigate the difficult situations and to give us a bit of advice and guidance. We don't want them to dictate how we should live our lives, but we want support and backup. Doesn't seek to deny the neurobiology and the impact of medical prescriptions or of treatments, various different treatments. It doesn't say that they're wrong, and what it's saying is they're not the only way. And I think most of us are reasonable enough to say whatever works for people works for people. And no one thing is right for everybody. But if people say, I don't want to take this, well, listen to them. Or if they say, I think I need more or I need less, well, let's have a conversation about that and let's try and manage, because that's really what self-management is about. It's about the negotiation and the navigation with people. They're the two documents that are the most recent ones. And I've looked at those because one of the things that's still happening in the policy documents is this whole notion of personalisation. Back to Anthony's definition, where it's down to the individual. You can lead the life you want. You can have whatever it is you want. And it's all down to you. And again, we see this embodied in the latest policy framework, where they say recovery is intrinsically about people experiencing and living with mental health issues in their lives and the personal goals they want to achieve in life, regardless of the presence or severity of those mental health issues. I would say you cannot abandon people without saying we put the services and the structures in place to support people in their goals, and we help them to actually identify which goals are best for them at different times, because we all have things that are better for us at one time in the course of our illness than in other times. So it's about helping people to manage and not just saying, off you go, away with you and do the best you can. And while everybody comes to that notion of, we've engaged with all of the service users and we've engaged with professionals and all the rest. And the whole idea is that the narratives identify that recovery is very much determined by what recovery means to an individual service user and through the articulation of their desires, beliefs and choices to realise their potential. There is another debate that's beginning to emerge which says, actually, you're only asking the people who feel they're recovered. You're not asking the people who feel they're not recovered. We're given nice fluffy ideas of what recovery means and the people who've been successful. And I see it at conferences, we see people, the same people trotted out, given the same things, same talks, lovely, very kind of motivating talks, if you're in the right place in your recovery. But not everybody is there. And there is now, this is where the critical review comes in to say, well, why haven't we got people who are challenging these ideas? What about the people who don't feel recovered? Who don't feel this is the only way? So where's their voice in all of this? And this is what we have to be careful of because we need to represent most people here. And again, the first principle is the centrality of the service user's lived experience. And that's very relevant, but that's only one individual. Everybody has I have a personal lived experience. But when I go to my cardiologist and I say, he says, well, I want to tinker around with your treatment plan. And I'm saying, well, hang on a second, I have a life to live. He's basing it on his years of experience. And because he wants to save the battery in my pacemaker, but I want to be out running on the roads of Kildare. And he's getting a bit frustrated with me because we'll have to do surgery sooner. And I'm saying I'll be dead long enough, so this is kind of my life here. But it's a negotiation between the two of us. So understanding that actually we all have our lived experience, but we have to sometimes manage that expectation in relation to what's possible and what's feasible in the constraints of the world that we're living in. So while yes, but a lot of people have similar issues. So while the individual is important, we need to think about the groups as well. We need to think about the wider group of people with mental health issues and what's happening to them. So who defines recovery? Lots of definitions. I'm not going to go through them all because I'm conscious of time, but you can see they range from this getting rid of all the symptoms, back to your normal pattern, back to your normal health. And that's grand if you had the flu. You're dreadful for a few days and then within 2 weeks you're back to your usual self. So that's the whole idea of recovery was originally thought of in these terms. We're not now thinking that everything has to be better before actually people can get back to their lives or never stop living their lives. In contrast to those notions about, kind of recovery being the remission of symptoms and the total amelioration of the impact of the illness, trauma recovery really looks at the whole notion that when we're impacted by an event, regardless of the nature of that event, be it a mental illness, a physical illness, psychological distress, be it being mugged on the street in a social way, all of those things have a lasting and indelible imprint on us. They change us in a way that actually we're always going to be changed. We can't go back to where we were before. So that whole notion that through our lives we change because of the traumas we encounter. And actually we learn to live our life in a different way because of those traumas. We have to change things slightly. We may be more mindful of our safety walking down a road. We may be more nervous. Or we may think, damn it to hell, I'm going out anyhow. I just won't carry a bag, I'll have my phone in my pocket or whatever. So we will change, we will alter, we'll move our lives in one way or the other. And the person internalises what's happened to them and they change. There's an active process of changing. And anybody who's had any sort of a serious illness, physical or mental, will know that the whole process changes you. You change and you become a different person because of that experience. And you don't necessarily ever get back to where you were, and neither do you want to really go there, because you are now a different person. You've grown in a different way. Most of the previous definitions of recovery look at outcome, but we're moving it really, trauma moves it into a process. And there's other people have talked about the process. And Resnick in 2005 talked about a process representing the belief that individuals, even those with psychiatric disabilities, can develop hope for the future, participate in meaningful activities, exercise self-determination, and live in a society without stigma and discrimination. And that's one of the first definitions I have seen that actually says what society needs to do here, that people who are living with these conditions need to be accepted and included. And more of the kind of the recent stuff is talking about social inclusion, about the absence of poverty, the absence of marginalisation, that recovery isn't just nice and fluffy and the individual's bone. The individual has to live in a society and they have to be included and accepted. And actually we need to be doing work at the societal level to allow people to live without stigma. 3 dimensions of recovery. Most has focused on the personal, and we've said a lot about the personal, and there's huge stuff out there that tells you what you should be able to do as a recovering person. Have hope, do all of these wonderful things. There is less about organisational issues and even less about what professionals should do. So we can see where the focus has really been. It's been up here about what the person with the mental health issue or the mental illness should do in order to recover. So we have really focused, and all the research has focused predominantly around that, with a few exceptions. We've talked about Anthony's definition. Patricia Deegan, again, a service user, and she has referred to the real life experience of the persons they accept and overcome the challenges of the disability. And that was very relevant in the 1980s and early 1990s. That was probably the biggest challenge, was to accept that people had their own ideas. And again, you can see the kind of development. They talk about develop important personal, social, environmental connections and confront the devastating effects, again, of discrimination through empowerment. So they're beginning to move some of the ideas. So the personal recovery core concepts. What's always put up there first is that the first thing, in order to recover, the person must accept that they have an illness. I know lots of people and work with lots of people who do not accept that they have a mental illness. Half the people who come to my Hearing Voices group don't have a mental illness. They hear voices that disrupt their lives. And so asking people for that acceptance as a kind of it's like saying, before we can give you treatment, you must stop taking drugs, or you must be clean before we'll allow you into a program. So we're putting an expectation there on the individual. This you have to accept. You have to agree with us that you're mad before you can recover. Okay? And I just have a little bit of a problem with that. You have to have a sense of hope for the future. Not everybody has a sense of hope for the future. Your circumstances can be dire and it can be really difficult. Hopefully people can get back to having a hopeful view of the world. And often that's through their interactions with people who can support them, that people can give them, help them to have a little bit of hope again. And then finding a renewed sense of self. That to me fits in with the trauma recovery. That I've come through this awful dark time in my life, I have thought about things, I've worked my way through it, and now I'm coming out the other end, but I'm somehow changed and I'm a different. And what I had thought my life would be like then may be different to how it's going to be in the future. And that's really that renewed sense of me and who I am. Then the elements of recovery, there's a whole range of things here. If you go through all the literature, they all talk about, again, the whole personal thing. Onken, funnily enough, talks about exchange-centred and community-centred. And then Lebouter talks about promoting citizenship, organisational commitment, supporting personally defined recovery, and working relationships. So there are bits out there when you start to look for them. It's not just all the kind of the fluffy stuff. It's all about you and what you want and how you're going to achieve that and what are you going to do. And isn't that wonderful? Look how far you've come. In actual, when we're not providing any good structures. Person-centred elements, hope is always there, sense of agency and self-determination, and these are all necessary and important. But if you're, just moving through a very difficult period in your life, you're not going to have all of this. This is something that vacillates, even in those of us who are well most of the time. We don't always have hope. I don't always feel a sense of agency and self-determination. I sometimes think, oh God, when can I retire? It's the whole thing is the expectation that people will be able to move themselves forward. And most of us just are struggling through on a day-to-day basis. And we try to make the best of what we have. So it's great to see all of these things, and we can help with people maybe to help them to think about what they need to do. But this expectation that all of these things need to be in place for you to recover may be a little bit unrealistic. The whole thing about recognising that change is possible. How many of us like change? I just hate the idea of having to do certain things. I mean, most of us resist change, and we go along with it because we really have to. Little things even that we don't want to do. But sense of being able to achieve goals, that is important for all of us. Environmental factors, finding and constructing personal meaning in illness. I don't know whether it's the illness, it might be about the experience of being through an illness and coming out the other side and thinking about deeper things in life and getting to know yourself. One thing I've found around working around people who've had mental illness or mental health issues, whatever way we want to label it, is that they actually have a deeper sense of who they are than I ever had. They know what makes them tick because they've spent a lot of time looking internally at themselves, knowing what's possible for them, what's necessary, knowing how to manage themselves, like getting enough rest. I mean, I have learned so much from the people I work with about how to manage life because they've had to. They've actually had to do more about that than I have. And I would look at some people and they're fabulous role models. One of the young women who attends the group on a Thursday evening, she's absolutely fantastic. She's a young woman in her 20s. She's such a rock of sense. She's been through the most horrendous experience. And she's there and she's able to talk to other people in a way that's really, I don't know what you're experiencing, but when I felt like that, this is how I might be able to deal with it. And she's really great at helping other people. And sometime in the future, when she's all her studies finished, she's going to be fantastic. We're trying to tee her up to be the group facilitator because she's far better at it than any of us. So it's about that recognition of the depth of knowledge and personal expertise that people have and that they do know about themselves, but not expecting them to be good at it all the time. Being reasonable in our expectations. Things like healing, and there's a lot of concepts here that are very close to kind of spiritual well-being and wellness. And there is that connection between having a sense of purpose and meaning in your life, maybe at a spiritual level, and kind of some of the recovery type ideas. The exchange-centred elements then just look at things like social functioning and social roles, and this is a major issue. Vast majority of people who have a mental health problem struggle with employment. We know that unemployment rates among people with mental illness are way higher than the general population. And actually it's very hard if you declare that you have had a mental illness to get a job. Very few employers are willing to support you. And that's a reality, it's a fact. You're better off if you'd been, Jack the Ripper and served 12 years or 15 years in prison. You don't have to declare it, you have a better opportunity of getting a job than you have if you say you have a mental illness. And that's a reality. So that stigma and those lack of structural supports in society still exist. So getting people into employment, getting people proper housing, getting them to have enough money out of the poverty trap, they're the really key things that actually, if you can make the conditions right for people, you can actually help them to recover. Asking people to recover when they're homeless and living in a hostel and trying to see their kids one day a week is really challenging. Things about social connected in relationships, it's really important, having your friends, having people you can talk to. We all have families and some of us socialise very well with their families, and other days we wish we were orphans. And that's the nature of families. Having friends and people that you can actually go and have a coffee with and have a laugh with, that's really important for us as a buffer to keep us kind of glued into our kind of reality. One of the studies I've done was on supporting socialisation. and looking at the impact of providing people with a volunteer partner and money to go out. Both are equally important, so that you can go out and socialise, and not people who've had mental health issues themselves, just a random person from the community, and set up friendships, get to know people and have fun, because actually having fun is really important. It's not all about intense talking and conversations. It's about just doing ordinary stuff that everybody does. Having social supports and having integration, community, feeling you're part of a community. Feeling where you live that you're comfortable, feeling that you can say hello to people in the shops, feeling that you can talk to the busman on the bus, not even nod to people when you're out walking the dogs. Ordinary stuff here. It's feeling safe and connected in your community. You may have come across this one. This is kind of the big synthesis that was done by Leamy and her colleagues. And she analysed all of the stuff that was done around personal recovery processes. And she came up with this term called Chyme, and connectedness, hope and optimism, identity, meaning and empowerment. And that kind of summarises everything from a personal perspective that people need to think about in recovery. When we look at professional aspects then, there's far less done around professional aspects. And there's no consensus about what is it that health professionals need to do to support recovery. Very little research done in this area, and while everybody thinks they know what they're doing, actually there isn't a huge amount of data out there. There is beginning to be a little bit of consensus developed by Slade and his colleagues and Boardman, where they're saying actually really it's how we do it, not necessarily what we do. So yes, the techniques are important, but actually it's the respect, it's the relationship between the professional and the individual. It's the respect, it's the recognition, it's the equality, it's the shared kind of connected relationship that I respect you and you respect me and we respect each other as people, both with different sets of skills, both with different knowledges and experience, and that together we're trying to work to find the best way forward. When they asked people who were using mental health services what they valued in professionals, the things that come up over and over again are the ability to build respectful relationships with service users in which the professional has a genuine interest in the person, but they're not just doing the job. And, you know, there's days when I'm there and I'm seeing students and I think, oh, it would be a grand job if there were no students. But actually you have to be genuinely interested in people. And I say to anybody coming into any healthcare profession, if you haven't got a genuine interest in people, well, you're in the wrong job, because you're going to get up every morning for the next 30 years and you're going to have to be interested in people. And if they don't actually tick your box, and if you don't want to ask them their seed breeding generation and have a conversation with them, and have I tell you a bit about me, you tell me a bit about you. If you haven't got that inquisitiveness about people, well, then you're probably not going to be really very good at what you do. And also that it's a humane and engaged relationship. And it was simple things, just asking how, your children were, or is your cat better? It's ordinary conversations. It's the recognition of the person. It's moving it beyond the professional and seeing the person as the person they are, and not just a patient. So when we looked at one of the things I've done over the years, I've looked at all the different literature around the type of things as professionals that I would like nurses working in mental health to do. And I've come up with kind of 10 kind of core competencies that I think any healthcare professional would be useful for them to use. And at the centre I have things like fostering hope, because I think that's one of our jobs that we need to be able to do, is when somebody doesn't have hope for themselves, it's very important that somebody else can say to them, it may take a while, but things will definitely get better. I have seen other people and they have gotten better, and that you can build the belief that the person can see a future and you can work with that person and just be with them. And it's often in the little things as well that you say. The ordinary little things like, oh God, you're looking great today. Or, have you got perfume on you? Or the lipstick really suits you? Or, well, if it's a man, it might be, that shirt looks good on you. Whatever. Simple, ordinary conversations. It's not the high-tech, high-spec rocket science stuff that builds hope in people. The balancing the power between the professional and the service user. That's a really big issue. if I come to anything with feeling that I'm in charge, well, then we've lost it straight away. I have to be able to say, I know certain things, you know certain things, so we're going to work it together and figure out the best way we can go and see how it goes. And, even when I do the group on Thursday nights, there's one or two people who still kind of think I'm in charge because I'm the facilitator. And we kept saying, actually, no, this is your group. You need to get on with it, guys, because we're just here. We collect the money to pay for the tea, and that's really what we do. We get the conversation going if it's not going. But other than that, you're working at this yourselves. So it is that kind of balancing that power and not thinking. Sometimes you have to be more directive with people. It's like, anything else. In life, you have to take control sometimes, but then you have to hand it back and let people get on with their business. Because at the end of the day, people are autonomous individuals. Supporting people's autonomy to make decisions, let them make mistakes. We only ever learn from our mistakes. We don't learn really from our successes. Think about the times you really learned something in life. It was often when you'd made huge mistakes. You think, I'll never do that again. But you don't even know what you've learned sometimes when you're successful. You think, well, how did I do that? It's like, when you're fixing your mobile phone and suddenly it happens, you think, oh, how did I do it? Whereas if you've had to work your way through it and make a few mistakes, you'll remember how to do it the next time. So supporting autonomy and focusing on the person's strengths and abilities. Then other things like supporting responsible risk-taking. We all have to take risks. It's helping people to see the pros and the cons of their choices and decisions. And just checking with them that they'll be able to live with the consequences. If you go for that job, and if they give you the bum's rush and tell you no, well, how are you going to feel and how will you deal with that? So supporting that, don't say, not saying don't go for the job, but just thinking it through and saying, right, be reasonable here with yourself. How will you put contingencies in place? It's like anything else, if we do it in life. If something doesn't work out, what am I going to do after that? And if it does work out, if you get offered the job and they say, can you start next week? How are you going to cope with that? So it's helping people to work through the consequences of their decisions without kind of putting in the spoiler, oh, I think you better wait now, wait till you're a bit better and you have more energy and then you can go and apply for the job. So it's not to be those negative things. Collaborating with people around their needs and around their goals and promoting self-management and shared decision-making. It's a whole other literature on shared decision-making, and it runs from giving people information right through to somebody coming in saying, well, actually, this is the medication I think I'd like to try. And it runs that whole spectrum. And people need to work those relationships out. And then the organisational bit, which is the most challenging, that organisations need to have in place systems that support people to recover and systems that support the staff to be able to deliver a recovery-oriented service. So there's no point in saying we're recovery focused if I'm expecting the person to say, you have to take your medication, and if they don't take their medication, well then I need to report you to the doctor straight away. So we need to put the structures in place that support recovery-based practice and will actually, stop risk assessing everything, because that's what really has become really the driver in health services. Everything is risk assessed. I call the CYA files, the cover your ass files. Everything is risk assessed. And that really holds us back in being able to take risks. And if we're trying to support positive risk taking, and we have everything totally risk assessed so that we won't be blamed for anything, it's very hard to help people recover in that kind of a culture. And that's why inpatient settings have real difficulties in working around recovery, because they're so kind of bound in. So again, we're back to Le Boutillier, I can never pronounce that name, but promoting citizenship, organisational commitment, supporting personally defined recovery and working relationships. So in citizenship, what do we mean? Basically, we're all citizens, but we mean it about the strength of people's connections, their rights, their responsibilities, the roles, the resources that society offer people through public and social institutions. So it's supporting people to have a full and fruitful part in the community and the society they live in. So that means everybody needs a home. We need some sort of occupation. It may not be employment, but it may be occupation. We need access to leisure activities, to social activities. We need access to healthcare. So there are certain conditions that we need to put in place if we're citizens, that we have rights. Equally, we have responsibilities to contribute and to take part as best we possibly can. And the relationship then involving close ties, supportive social networks, and associational life in one's community. You know, a couple of friends are worth $1 million. People that you meet for a cup of tea and a chat and a bit of a laugh, or to go to the movies with, or to go for a walk with, they are really the kind of the medicine in this world. They're the people that keep us kind of ticking over. And that's what being a citizen is really about. Basically, what this person is saying is that mental health services, that should be their core role, is to promote citizenship. So helping people to take their place in society, not just recover from their mental illness, but to be full citizens with the rights and responsibilities. And that the organisation has a commitment to ensuring that work environments actually support recovery-oriented practice, so that we put in place the structures. And then supporting personally defined recovery, that it's seen as the core and not just as an add-on, and that the working relationships demonstrate genuine desire to support individuals to fulfil their potential and shape their own future. Now, there's as said, inpatient youth services are actually challenged in particular to promote recovery because of the nature of organisations. It's very hard if you're running a hospital or you're running, a very restricted services, because you are required by law to fulfil certain requirements, and that can be quite restrictive. So this person, Chen et al., had a good look at what were the barriers for organisations in actually adopting recovery in their hospitals, and what do providers need to do to change from their existing slightly custodial, slightly coercive practices in the best of services that happens, to move towards a more recovery oriented. And they identified three major kind of points of tension: the provider level tensions, the environmental factors, and personal level. So they found that actually the routine and non-critical application of the medical model was a big impediment. If the only game in town in a hospital service is medication, 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 that actually had a big impact. I would say that actually isn't the case in most services now. Most places will have a combination of different therapies. The operation of a custodial framework and risk control principles generate a sense of segregation and restriction among patients. That's really evident when you've got somebody who's very acutely unwell and is maybe a danger to themselves or a danger to others. And we are having to work to contain them. I'm sure you saw the stuff the other day that the Supreme Court have said the law around detaining people actually is unconstitutional, but they're not going to change it for 6 months until people can get their heads around it. So there's lots of difficulties because legally we have frameworks that kind of bind us into certain circumstances. And if we don't fulfil those, then you end up in the High Court or whatever. So those practices are very restrictive. And what happens is then the result is limited choices and constrained communication and passivity. So the organisation is constrained, which in turn constrains the patients who are using the services and reduces their ability to have a normal kind of experience of life. We've said about the non-humanistic, non-healthy, discouraging and lacking this, that the environment lacks stimulation. The tensions between maintaining order and ensuring patients' choices, preferences and satisfaction. That's always a tension. If you have to serve the meals at 1 o'clock every day, people can't decide, I'd like my lunch at 11 or I'd like my lunch at 3. So personal choice is limited. No matter how you try to do it in any organisation, it's very hard to foster personal choice and satisfaction. Limited resources resulting in feeling of segregation. And for people who come into hospital, they find that actually, if I could go home and come back in. But sometimes it's, we bring people in, we cut them off from the community, and they kind of feel apart and adrift. There's a movement going on in the general hospitals at the moment where they're saying, stop putting people in their pyjamas when they come into hospital. Let them live in their outdoor clothes. And what happened in some hospitals, the staff have come in their pyjamas instead and walked around in their pyjamas. So this whole notion that somehow you take over the person's life. Now sometimes if you're very sick, you just want to get into your gym jams and you want to get into bed and you want somebody to mind you. And what we're saying is it's people having the choice of that spectrum. That there are times when we all need to be minded and looked after and have our meals put in front of us and somebody to encourage us to eat. And then there are other times when we want to be more autonomous and do our own thing. And really what recovery is about allowing that range of activities. In the environmental and the hierarchical power structures, the vulnerability to power imbalances between professionals and patients and even between the different professionals in the organisation, and dependence on the hospital's submission and decreasing activity and engagement. People kind of stop doing their normal stuff when they come into hospital. You know, they kind of, you feel, oh, I'm in hospital, I have to do certain things a certain way. I'm sick, so I have to behave in a certain way. And the hospital kind of encourage that because it's easier for us to manage. If you're sitting in bed or you're close to your bed, well, we know where you are. We know you're safe, so I don't have to do too much running around looking for you. So it suits the organisations. At the patient level then, when patients are very acutely unwell, particularly if they're very distressed and maybe having psychotic symptoms, maybe being very persecuted by voices or whatever, that can be a real challenge to keep people safe when they're at that level. And in order to do so, there may be a resorting to locking doors or restraining people in smaller areas. And sometimes that is necessary to protect people's safety. That has an impact on their people, you know, it challenges the organisation to try. You don't have enough staff to have one person with one person all the time. You know, so you may have to constrain people's freedom, and that makes it really difficult. And patients who present with behavioural problems such as aggression and intimidation are often the most challenging. That can be really, really difficult. We also get that from students. We had a student the other day who verbally abused the clinical placement coordinator because he hadn't taken action to get his assessment signed off. So he verbally abused, stormed out, and then came back and said he wasn't leaving without a fight. And so we'd often have students come into our offices and demand a higher grade. So it's not just impatience at that aggression and that kind of behaviour is evident. That's evident in society. So we have contingencies, like you leave your door open when you're seeing students, just in case, and you hope you tip off somebody in the office next door to you to say, I'm seeing such a body, we just keep an eye if you hear anything, because we have had people threatened and that kind of stuff. And these are, you know, ordinary adults who you would think would be well behaved, but you know, that's life. If you look at that group of youngsters who got on the trains last night and wrecked the place down in, you know, all the graffiti all over one of the DART stations. It happens in society, and there's that level of aggression that's there. So it is very challenging to manage that. And then on the personal level, then you've got things like motivational problems. There's a fine line between people who are not motivated or having difficulty being able to participate, and staff being coercive. Like where do you draw the line between, no, I really can't do this, and I'm forcing you to do it? And that's a real difficult one. You know, or am I just kind of being laissez-faire? She doesn't want to do it, so leave her to her own devices. Whereas maybe another little bit of encouragement would help. And that's something that we always are trying to work out. There's no answers for that. Anyway, I'm going to whiz on because I'm aware that's just a summary of all of those things there, and just puts them all together. So, just to return to our questions where we started. We know that the evidence does say that actually for a significant majority of people, recovery is considered the desirable outcome and is deemed possible. But most people feel that that's what they want to do, and it is possible. It also supports the majority emphasis on personalization and on normalizing individualism. So me saying to you, it's whatever you want, You have your own ideas and goals, and actually they need to take precedence. And most people want. That's the kind of society we live in, and we all need to think of ourselves. Policymakers, researchers, professionals and service users appear to be operating off the same set of ideas, which is good. We all seem to be on the one page. But as we said at the outset, there may be certain problems with that. There's very limited evidence available which examines the potential limitations of the recovery approach. So, what are the limitations here? Where do we need to put extra efforts? What else do we need? Because we've only talked about the person. I said most of the work is around what the person needs to do, but not what society or what organisations or health services need to do. A recent study that I was involved in, one of my colleagues, Donal O'Keefe, we looked at people who had been identified as having a first episode of psychosis 20 years ago, and they've been followed through over the 20 years. And last year we interviewed 20 people, some who said they were recovered and some who said they weren't recovered. And we looked at what they were saying about recovery and the differences between the people who felt recovered and the people who didn't feel recovered. And actually it's one of the first papers that's been published that has focused on people who haven't recovered. And those who did not feel recovered perceived that there was a reduction in the quality of their care, the absence of outreach, less comprehensive assessment and less interaction with and attention from practitioners. So they felt somewhat abandoned to recovery. Get on with it yourself. And actually, if you still need assistance after 20 years, well, there's not really much more we can do for you. So they felt somehow abandoned. And these people were very well. I would have probably put half of them back into the recovery mode and said, yeah, I think you're recovered. But they didn't feel recovered. And I think that was the critical thing for the individuals. Also, some did not identify with the concept of recovery and felt deserted by services. They felt kind of left to their own devices. The recovery approach was seen as the removal of structure within and the dumbing down of programs. And this is the quote from one of the people here. It says, well, I think someone was talking there that they have moved from a medical model to a recovery model. It was a day centre. So everything is a bit freer and easier. It's a bit of the lowest common denominator. The discipline is terrible in this place. There might have been regimentation before, but it's a case now of lack of conviction. There is no one saying, take this, it will do you good, or this is it. So that absence of people feeling, actually, I've nobody to support me, feeling that absence of structure and support. It's a kind of it's something we need to be thinking about, that there are people who don't feel recovered and feel abandoned. But yet we're all fluffy and nice about the recovery and how wonderful it is. So we just need to maybe temper our glee a little bit. Participants believed that within the modern system there was no acknowledgement of how there are different ways to recover, and some noted a reduction in empathy and a more anxiety-provoking atmosphere. So they felt actually people weren't listening to their side of the story, that because you weren't getting with the programme, well then actually you weren't getting with the programme, so we didn't need to. It was down to you, it's your recovery, you need to take charge. And that somehow doesn't work for everybody. And I suppose that's the note that I probably want to end this on, is to say that really, in essence, recovery needs to be more of a political movement than just a soft, nice, all about you. We need to be talking about reducing social exclusion. And in that way, we need to be thinking about reducing disadvantage, including poverty, hardship, material deprivation, and personal distress. So we need to be thinking about what people are experiencing, not just when they come to us in a clinic or whatever. We need to know what their lives are like. And actually, that's a societal issue that we need to be addressing. We need to be promoting the power of the patient to challenge notions of dictatorial treatment and negative professional opinions, including the presumption of recovery. Okay, so if we're really honest about this and if we really mean this, well then we have to accept recovery is not the same for everybody and it's not possible for everybody. And we need to not go where we've been already. We need to remember we made mistakes in the past. We need to promote the individual with mental health difficulties to the centre of his or her treatment. So we need to think, actually, we need to listen to the person. They won't always know what they want, but our job is to help them to find what it is they feel they need and want. And when they know what it is, well then to go with the flow. And promote inclusion through rebuilding a positive personal and social identity. So supporting recovery then is complex. It requires all partners to be involved, service processes, the service user, the system and professionals. It needs to move beyond a traditional focus on recovery and needs to move towards promoting citizenship and integration. Support the construction of partnerships, social and interpersonal relationships, which in turn support companionship and access to resources. And supporting people with mental illness in exercising the rights and responsibilities of citizenship is a precondition for the recovery and not a reward you get when you're recovered. So we need to be doing this at the get-go. From the time the person presents with a mental health difficulty, we need to be talking recovery and working with them in a recovery-focused way. Not saying, well, we have to wait until your voices are gone or you're less depressed or whatever. We need to be helping them to reclaim or get into the systems. And that's just a whole range of resources. I've sent on a couple of papers as well to Barbara, and I've asked her to put them up with the talk so you can access some of those. And they're recent Irish research that we've done. So it'll give you some idea of what's happening in the Irish context. Okay, that's me finished. Thank you very much.